2 more minutes to start the session, but for the speakers, let me introduce myself. I am Dr. Anupama Gotimokula. I'm Vice President of AAPI, and we have been doing these teleconferences. We have done like 5 or 6 or 7 recently, and I think our physicians and community, it is helping a lot to get more updates and what's going on right now, any new treatments or how the prognosis are, how everyone is doing everywhere all over the country. So this is what we've been doing, and I thank all the speakers of today's teleconference. I will introduce you, and after the introductions, we'll have Dr. Suresh Reddy talk briefly, and then we'll talk our speaker sessions. And along with me, I have Dr. Lokesh Idara. He is from Michigan, and the allergy immunology specialist in Kalamazoo. Welcome, Dr. Idara. And let me introduce hi attendees. Welcome to this evening session, and hope we will be able to give some information, message, and Q&A session will be there, and participants will have an opportunity to ask their questions or text me the questions, me and Idara, so we'll ask those questions. So today's evening session, we have Dr. Mujahid Hussain. He's pulmonary and critical care physician from Medicine Northwestern Kishwaukee Hospital, DeKalb, Illinois, and he's been practicing in Chicago since 1999. And our second speaker is Dr. Mukram Siddiqui. He's Chief of Division of Cardiology, Detroit Medical Center, Associate Professor of Medicine, Wayne State University. And third speaker will be Dr. Tarak Vasavada. He's Medical Director, Huntsville Hospital Behavior Service, Clinical Professor of Psychiatry, University of Alabama, Birmingham. And our fourth speaker tonight is Dr. Vishnu Chundi. He's Senior Partner, Metro Infectious Disease Consultants, Chairman, Infection Control, St. Francis Medical Center, Evanston, Illinois. And we also invited Dr. Deepta Nedunchesian. She's the internal medicine infection physician from India, but she could not be able to join our conference call. And I'd like to have our president, Dr. Suresh Reddy, if he's on the call, to say a few words. Dr. Reddy, are you there?
Yeah, thank you, Anupama. Can you all hear me?
Yes.
Okay, good. So first of all, I would like to thank my other coordinator, actually, Dr. Mohammad Ziaur Rahman. He's a ER physician and is the president of Bangladesh Medical Association, but unfortunately, he's not here today because his brother just got admitted to COVID in Stony Brook, Long Island, and is being intubated, and he's also having fever and cough, so he couldn't join. Dr. Idara and Dr. Gotimokula will be coordinating and moderating the session. And I want to thank all my good friends and speakers, Mujahid Hussain, Dr. Mukarrab Siddiqui, Dr. Tarak Vasavada, Dr. Vishnu Chundi, and Deepta Nedunchesian, who is the chair of this COVID committee. Thank you all for joining, and it has been a very wonderful experience, and hopefully more people will join soon. And we have we almost did, I think, around 10 sessions till now. We had almost audience up to 500, so soon it will go up in the next 10 minutes. So yeah, Anupama and Lokesh Idara, you can take over, and thank you for joining.
Thank you, Dr. And let me ask Dr. Mujahid Hussain to give us a brief his experience with COVID patients and what information you have for us today.
Good evening, everyone. This is Mujahid Hussain, and I'm practicing in Northwestern Kishwaukee Hospital in DeKalb, Illinois. And I have seen a lot of patients, both different spectrum, mild cases as well as the severe cases. And unfortunately, this is once in a lifetime that we are going through. It is a significant health threat to everyone. And it started in China and it has spread to the rest of the world. And every day we see a lot of patients coming through. Um, uh, I have seen patients who are asymptomatic as well as mild symptomatic to very severe cases. And when the pressure, the typical patient presents with fever, cough, and sore throat associated with other symptoms like fatigue, aches and pains, somebody with nausea, some diarrhea. And, they are triaged in ER right away and they are diagnosed with COVID by nasopharyngeal swab test. And they are put into the isolation immediately. And but I have seen a lot of patients decompensate very fast within a few hours, going into acute respiratory distress syndrome and being intubated with all complications of multisystem organ failure. It is very sad to see all these patients go through this problem so rapidly. And for us, we should be taking care of these patients as always. And I would like to get some other experience from other physicians, and I'll be able to answer your questions later. Yeah. Hello?
Yes.
Yeah. So I'll be answering your questions later. So I would have other.
Next speaker, go ahead.
Yeah.
Anupam.
Hello.
Okay.
Anupam, are you there?
Yeah, I'm there, but
next speaker, go ahead.
All right. This is Dr. Siddiqui. A very warm welcome from Detroit. I am an electrophysiologist and a cardiologist, and I've been in practice for the last 25 years. What I'm going to touch today, this evening, is about the cardiovascular manifestations of COVID-19 patients, the cardiovascular manifestation in COVID-19 patients, and what are some of the queries that we are facing as we are managing these patients. As you know, this is more than once in a lifetime thing that we are facing. The last time the world faced a pandemic like this was 1918, approximately 102 years ago, related to Spanish flu. And at that time, several million people had died, and hopefully we will not have such bad outcome this time. So the cardiovascular manifestations that we are seeing may not be totally related to COVID-19 infection, but anything that stresses the body in a patient that have underlying risk factors for cardiovascular disease, it will manifest some degree of cardiovascular disease in these patients. As Dr. Hussain has alluded to earlier, a lot of patients are being affected and a lot of them have severe disease. So what are some of the things that we are seeing as a consultant that I'm seeing in my practice? In hospitalized patients, especially those in the ICU, we are seeing a lot of arrhythmias, and these include sinus tachycardia, PACs, PVCs, atrial fibrillation with rapid ventricular rate, non-sustained ventricular tachycardia. And I've seen one patient with sustained ventricular tachycardia, which was monomorphic, and there was another patient with polymorphous ventricular tachycardia that had to be shocked. Whenever we talk about arrhythmias, there is the substrate and the trigger. So in COVID-19 patients, a lot of them are hypoxic, hypokalemic, hypomagnesemic. A fair amount of them have underlying ARDS. So these kind of arrhythmias are seen in such sick patients irrespective of COVID-19 infection. So we cannot make a direct causality that this is because of COVID-19. In addition to that, troponin elevations is being seen very frequently in these patients. And the troponin elevation, especially with the high sensitivity troponin, it could be related to supply-demand mismatch, and usually these patients have poorer prognosis. Patients that have pre-existing structural heart disease, especially those with ischemic heart disease or dilated cardiomyopathy, there is very high incidence of exacerbation of heart failure in this patient. One of the studies coming out of China, again, coming out of China, you have to take it with a little bit of, grain of salt, has talked about patients with COVID-19 presenting with new onset cardiomyopathy. And there was a suggestion that the putative mechanism in patients that are developing with, that are presenting with cardiomyopathy may be related to COVID-19 infection. The data that is coming out of Italy has, especially the biopsy samples, when they did electron microscopic examination, did not show direct COVID-19 infection. And one of the proposed mechanism is the elevated cytokine levels that are being seen in patients with COVID-19. So a lot of times, the risk markers for adverse outcome that I have seen in my observation is lymphopenia. And anytime the markers of inflammation such as C-reactive protein or troponin values are elevated, then we are seeing bad outcome in these patients. The other two things that I wanted to touch upon is the use of ACE inhibitors. And a lot of times ACE inhibitors are used either for management of hypertension or congestive heart failure, or as a renal protective agents in patients that have diabetes. Whenever we use agents that affect the renin, angiotensin, aldosterone system, the ACE2 levels go up. Whenever angiotensin converting enzyme levels go up, one of the mechanisms through which COVID-19 acts is through receptor binding. And when we see these higher levels, there were concerns that use of ACE inhibitors and ARBs that give rise to higher levels may have an adverse effect. But the ACC/AHA have come up with guidelines that we should continue using these medications because the risk of stopping is, risk associated with stopping is much higher than risk of continuing it. In addition, NSAIDs, if they have to be used, they can be used, but with caution and with lowest possible dose. Again, there are no findings that indicate that it's an absolute contraindication to stop non-steroidals. And finally, I hope some people asked me during the QA session about use of hydrochloroquine, chloroquine, and azithromycin in patients that have been affected with COVID-19. I would like to address that later on. Thank you very much. I think my 5 minutes are over.
Thank you, Mukul. And we'll go with the next speaker. Here, Tarak Vasavardi. He's from Alabama, psychiatrist.
Well, thank you, Anupama, Suresh, and the whole AAPI for giving us a chance to express ourselves and teach other people. I'm a psychiatrist at Huntsville. I have taught at UAB for the last 25 years, and I have special interest in this topic because how these people deal with it. Up till now, we have dealt stress in individual level, but we are talking about individual level, community level, and the whole nation and the world level, which we never seen it before in our lifetime. So basically stress has three events: the stress in event, and then our reaction to the stress, which is both physical and the mind. And the third part of reaction is the adaptation of the stress. So that's what I'm interested in, how people do well and how people survive. So that third part, if you come out right way, which is bouncing back to a good functioning again, is called resiliency. And it's important that we take care of ourselves so that we can take care of other people. This kind of a event is unusual in the sense, like I said earlier, that it hurts us all at individual level because we have several firewalls that we work with. We have several balance that we use: work, our physical and mental health. Then we deal with our relationship, our money, and how we feel secure about our security with the finances, and our spirituality. So this has affected all the 5 levels of our, except relationship probably, maybe not yet. but as stress goes by, it will affect us too. So the resiliency is a word is called bounce back or hardiness. A lot of time it has been studied way back in a Jewish concentration camp. And this is how we feel in some sense, how these people must have gone through, am I right? How these people have gone through this concentration camp, how people have gone through severe PTSD on the war front, young brave soldiers who had no knowledge about what they are facing. And this is what our residents and the doctors in the ER are facing. So the element of survivorship or the resiliency has several factors. One is the active coping style, which I'll come back to it a little bit later. Physical exercise and mind exercise, basically meditate, which will increase our endorphins, BDNF, brain-derived neurotropic factors. Then positive outlook. We have to keep our optimism, our hope. It is kind of thinking that this could be a temporary problem. We have to, all the studies always show that humor is a very important part of it. So I know that a lot of people are making jokes on WhatsApp about other things, but as long as it doesn't get personal, humor is okay. We should believe that we are not a victim. We are going to survive these things, and at some level, community will come out strong. Creativity, of course, how we create, how people are making masks now, how people are helping others is important. The fourth part is the moral compass, meaning where we came from. We came from a family background that taught us right values. Our morality is important, and we keep that. Our altruism, meaning helping other peoples. Religion, spirituality, or faith in any sense. Some people are not believing in religion, so somehow they have faith in the whole system, how it will work out. Social and community activities. So seeking social support is important to ourselves. We have to follow our community outreach and follow some role models, what they are doing it. And then cognitive flexibility, meaning cognitive reappraisal, where we are today and what will it be later on. Count our losses, count our blessings, count what we have it, and then go from there. The active coping styles basically focus on appraisal focused, which is how you kind of appraise the event. So it's a logistic analysis and mental preparation for the event. It's cognitive redefinition. So basically you understand that some of this community may not fight back as well, may not come back to it. Cognitive avoidance or denial. So sometimes denial minimize the crisis, and that's okay too. Denial is not always bad. Some resiliency studies have showed that some denial is okay. If you've seen the movie, Italian movie, those Life is Good or so, I think important to see that. Problem focused coping, which is basically we seek the information support. We understand the problem that it is, how to solve the problems, and identify alternative rewards situations. So that is important. Emotion focus, that is internal. So this is something that we have to do it. How does one control our emotions? Effective regulation, meaning not let our emotions go high and low. Emotional discharges, meaning venting, humor, etc. is important. And resigned acceptance, which is a big word, meaning accept it that this is beyond your call. We are on earth due to somebody else, a higher being, and we are a small part of this whole universe. And we need to understand that we can be taken out any second by smallest organism that is existing. So those are the ways that someone can cope. There are several kind of domain of these things. And it's important that we realize that this is not the end of it. If we really try hard and fight it, we have to stay strong. As I was saying earlier, you know, our work has suffered, so we don't have support as much as we used to have it. We are staying in our home, doing less and less. Even at work, we are not talking as much. Our physical thing may have suffered because we are not exercising, gym are closed, but we still need to continue. Our relationship is the most important part, which is important, but if you are living at home, the relationship is not good, so I can understand how it would be stressful. And of course, finances, we are struggling with that too. So that again, we need to appraise. You know, we are going to come out somewhat poor, and how much poor? I think everybody's going to come out poor, so I think it's okay. And spirituality part, which is again, we need to seek what we are, where we are, where do we stand? We are a dot. like I said, a small dot in the universe, and it gives us an idea what it is, you know. So thank you again, giving me a chance to talk about this.
Thank you, Gauraji. And let me introduce our last speaker, Dr. Vishnu Chundi. He's infectious diseases specialist from Chicago, Illinois. Dr. Chundi, are you here?
Yeah, I'm here. Thank you for giving me the opportunity to talk to everyone here. So I'm part of Metro Infectious Diseases Consultants, we're at over 200 hospitals. We're about 100 plus doctors, which serve multiple states, including Illinois, Michigan. We are at basically, I think, 12 states, including Georgia. Right now we have well over 1,000 patients with COVID infections, mostly in the intensive care units in the hospitals. So we have a bird's eye view of what's going on in the country. I'll address three things. First, the physician's aspect of it. So from a physician perspective, all of our providers have been greatly stressed. We have 2 people now infected with COVID. And our NPs, PAs, everyone else is quite stressed about this. It's created what our prior speaker was talking about, a great deal of anxiety, psychiatric issues. You have people reaching out, they're socially isolated when they get home, and then they almost have like a post-traumatic stress disorder when they go to work. They're also at high risk for getting infected, as we've already had several infected. We expect at least 20–30% of our doctors to get infected over time. The second issue I'll address is the patient care issues. Right now, we really don't have effective therapy for these patients. We're seeing a biphasic illness in our patient pool, and we really have a fairly large amount of experience with this because we're everywhere and we're huge. We're the largest group in the country. We've noticed the biphasic illness where initially people get infected with the viremia, they get more of a sore throat, upper respiratory infection, followed by a lower respiratory tract infection, followed by an immunological response with almost like a hemophagocytic lymphohistiocytic syndrome, high inflammatory markers, C-reactive protein, troponins, as well as ferritins. The management of this has been all over the place. Our current strategy is to use hydroxychloroquine, plus minus azithromycin. The azithromycin stuff from France is actually very shaky, may cause more problems with QT prolongation, cardiac issues. And then we add tocilizumab as the inflammatory markers increase. Steroids actually have come back into fore with us, and we're trying to get convalescent serum. Mayo Clinic has a program for that. We're trying to get our own program here in Illinois. I'm in contact with the governor's office tomorrow. We actually have a phone call with Chicago Medical Society. The last aspect of it has been the patient care aspect of this. Patients have been isolated. They don't have their family members visiting them, which has created a huge amount of stress where you're calling people. We don't have a doctor-patient relationship anymore because most of our patients are intubated and are very sick. We're calling people when they get admitted. We're calling people in between. And it's been very difficult because we don't really have a face-to-face conversation. We're doing this virtually. And it's very hard to have these bad conversations with our patients, which has been very traumatic, and their family members, to tell them, you know, your 36-year-old husband is dying and there's not much we can do. Can we make him hospice, DNR, and those sorts of things. From an AAPI perspective, I would certainly encourage AAPI to take a position about physician wellness care. The second thing I would encourage AAPI to do is talk about end-of-life issues, about not putting more of our doctors at risk by, fundamentally resuscitating folks that have no hope. I'm not talking about the ones that go into torsades or, polymorphic VTAC or monomorphic VTAC. I'm talking about people who we just can't ventilate anymore. So I'll stop there, and then we can take questions afterwards.
Thank you, Dr. Chundi. And Dr. Idara, you want to open up the questions session now?
Yeah, sure. This is Lokesh Idara. Thank you so much for great speakers and our guests. Anupama, do you have any questions, or should I start what we have?
We have one more speaker joined today, Dr. Saud Anwar. He's unmuted, right, Vijaya?
Yes, I am.
Hi, welcome. And we were a little bit, we're not sure, but would love you to introduce yourself and let us know where you practice and yeah.
Sure. I'm Dr. Saoud Anwar. I'm a pulmonary critical care specialist out of Manchester Memorial Hospital, chairman of Department of Internal Medicine. Over here as well, affiliation with University of New England College of Osteopathic Medicine, also with University of Connecticut. And I'm also vice chair of the Public Health Committee for the state of Connecticut. So I'm going to talk about crisis medical care and what we have forgotten. I think many of the people, if they are trained outside of United States and if they have been trained in South Asia, we have a better understanding of what crisis care is. Because on a given day, depending on which part of the country you're in, which part of the city you're working in, we are in a critical situation where the resources are not enough to be able to take care of the patients. But in the last many years in our practice in the United States, we have forgotten about some of the things that we had learned when we were in medical school. And right now we are being expected to manage a complex situation. So when we are looking at these complexities, I would divide them into three broad categories. For any healthcare system to work effectively, you need to actually have a space. Number one, space means where are the beds going to be? Where are the patients going to be? The second part is the staff. And you need to have the team, you need to have the people who work collaboratively, and then that actually allows us to be able to provide care. And the third thing is supplies. You don't have the antibiotics, you don't have the ventilators, you don't have oxygen masks. How are you going to be able to manage the patients that we need to manage? So these three S's, which is staff, supplies, and space, this is what is going to be challenged in the coming days, depending on where you are. It's a matter of time the entire country would be impacted. Right now, if you look at what's to come in other parts of the country, you look at what's happening in New York and in parts of Connecticut. So then if we are looking at those aspects, you move on to the care that we provide. Again, the care can be divided into the conventional care that we give every single day to our patients. That is the standard of care that we are providing. And if we are unable to, if those three things are not working, and then that's what's happening right now, we move from conventional care to contingency care. So right now, most of the people are in contingency care in the country, where we are planning how are we going to take care of the space, how are we going to have enough ventilators, are we going to use anesthesia machines, do we have enough IV fluids that we have to give these patients, are we going to have enough antibiotics? So we are adjusting our contingency. And the third level is going to be crisis. The crisis is when we are far above and beyond the requirements for space or not. We are actually closing one room, which are meant for 2 patients. We are actually putting in multiple people in the intensive care units, more than the intensive care units are intended for. And one person is managing 20 patients instead of 5 or 6 or 10. So that is where the crisis is going to come in. The challenge we have is the administration of the hospitals, the governance of our various states and the various organization boards. They expect us to provide conventional care in crisis situations. So we'll be held to the standards of a conventional care in the absence of a conventional situation. And we're already seeing lawyers put advertisements out to the patients stating that if you feel that you've not had the right care by your clinician, call us and we will not be charging you a single cent till we actually sue your physician. So we are in a messed up situation at so many levels because we are not internally consistent with recognition of the crisis. We first have to manage the crisis, but the various governing bodies have to be front and center to be able to say this is a crisis. And this does not mean that every single physician who's providing the care is going to be sued or going to be treated differently. So those are challenges at a different level that we have to look at. I'll stop over here. I'm sure this is going to generate some good conversation. Thank you so much for having me. I'm honored to be a part of this conversation.
Thank you. Thank you so much, Dr. Amber. And I think we will start with the questionnaire. Dr. Idara will start the question.
Yeah, let me start the first. On the screen, we're seeing some questions. This is about the outpatient, where myself and a lot of doctors have outpatient clinics. How do we see? Do our nurses wear PPE in the office for asymptomatic patients? Is it safe to see patient in office now, or should only continue telemedicine? When do we, if we need to do testing, about the mask? So we really appreciate the answer for that questions, outpatients.
Yeah,
Dr. Chandi here. Okay, go ahead.
So, you know, when patient is in outpatient, they have mild disease, mild to moderate disease, and we should encourage them not to come to office in first place. And, you know, the patient calls your office and the nurses or your secretary should ask some questions to find out what's going on and then decide. And you should encourage patient not to come. But if they do come, and yes, you have to take all the precautions like putting a mask right away. And we should recommend that they stand at least more than 3 feet away from their receptionist before they are checked in. And after they are roomed in, then obviously you have to prioritize and see the patients immediately so that you can discharge immediately. So any other suggestions, I will be happy to answer.
Yeah. Anyone else answer the same question? Otherwise, I will add something to this question. I have some answers.
Yeah, Dr. Chanda here. So we've created a streamlined process for our offices. So first thing is we put a physical barrier between our receptionist and the patient. So we erected basically a plexiglass screen that prevents the droplets from, if someone is coughing or something, to falling on our intake person, because a lot of the people who are sitting at the front desk can get infected. The second thing is we use a lot of telemedicine, which gets, by the way, reimbursed exactly the same as seeing them in the office. The third thing we've done is we've ensured that we have minimal contact with the patient, and we put a mask on the patient first, and we walk in with the mask and gloves. Almost all of this transmission that's taking place, as evidenced by the recent MMWR article, is from basically touch, and it's like basically like a norovirus on steroids that gives you ARDS. So everyone is so obsessed about masks and these sorts of things, but I think the actual transmission that's taking place is probably 20–25% by droplets, maybe 1 to 2% by airborne, and the rest is all touch, hand hygiene, touching the areas that people walk into. So we've enhanced our cleaning of all the flat surfaces in our offices, so they get cleaned on a regular basis to try to decrease the viral patina. So there's actually protocols that we put together I'd be happy to share with AAPI, and so they can all include that into their office practice.
Thank you, Dr. Chindu. This is another thing to add. I just went to post office today. They are erecting the physical barriers, like, and also Meijer and Walmart are erecting the barriers. So I think we recommend universally, no 3 feet, just plastic barriers. They can talk on the cell phone with the receptionist, but the barrier is must be saved the front desk. Even we're thinking in allergy injections, how to make the barrier in our office to maybe a plastic curtain, etc. Okay, next question, Anupama. Can you ask the next question?
Yeah, this question is to Dr. Chundi or Dr. Anwar. You can answer. Okay. Any neurological manifestation from COVID-19? Any structural deformities seen on the MRIs or any scans? So anyone can answer this question.
I'll let Dr. Anupama go first.
Yeah.
You know, I'm not aware of any neurological at this time. You know, I think it's too early to say that because most of the patients who are in ICU are sedated and paralyzed. So I don't think we can judge it at this time.
Yeah, I agree with that.
Okay, next question we have is, what are the outcomes of using Actimera, is the IL-6 blocker, Actimera?
Yeah, I can take that. So we've probably given 100 doses of tocilizumab or Actemra, and we found a very interesting pattern. Actemra has a long half-life, about 6 days. We're the largest dispenser of Actemra in the country, actually, our group, and we have a lot of it on stock. And the interesting thing we've seen with this is when we give it, they actually have a pretty good response. So I've given about 10 doses, and more. And we have a good response in the first 24 hours. Guys who are on 3-4 pressors come off, 2 of them, but then they have rebound. And we give a second dose within 12 hours, and some have done well. Actemra with steroids has been very useful. So now we put a protocol in place where we give Actemra with methylprednisolone 40 twice a day at the same time. Because now you're getting to the face of, it's very similar to the hyperimmune response you get when you have some of these autoimmunizing viruses, like what's that silly virus in India that I'm sorry, I'm slipping my mind right now because I'm so COVID mediated right now. Not chikungunya, but dengue. Right, it's like dengue autoimmunization, right, exactly. And so that's been a very useful combination of giving Actemra with the steroids, and that's basically muted some of the hyperimmune that we've seen, phenomena that we've seen. So we've used a ferritin level of 10,000 or above with the person needing increasing oxygenation, and then we go ahead and give them Actemra with steroids. We think it should be used early on before they get on pressors and stuff, because once they're on pressors, it's really difficult to figure out, if you can really help them.
Thank you.
Thank you.
There's one more question I'm asking as an asthma allergy specialist. All viral infections triggers our asthma patients. We give some prednisone at home. If their pulse ox is 95, 5 days of prednisone will take care of them. It prevents admissions. There is one report I saw from China. The early administration, probably before going to the hospital, at that time with respiratory wheezing, starting a small dose of 5 days prednisone. Does anybody have a take on that?
Today, it recommends going easy on steroids because of prolonged hospital course and higher risk of complications in COVID-19 patients. Again, I'm not an intensivist, but Dr. Hussain can elaborate further on the use of steroids in this setup.
Early.
I
not
think
before the hospital.
Your asthma flare up anyhow with steroids, but these patients are high risk because of immunosuppression to get more severe disease, and like a Midrol dose pack would be an ideal at this time.
Yeah, that's what I mean. Okay, next question, Anupama.
So a question from a physician from New York, a very emotional question. So when are medical organizations going to do something about the utter injustice being done to medical community by asking them to work in these suicidal conditions? If you all have any answer for this question?
Yes, I can take that. So again, this is something that is happening across the country, and I feel strongly that when somebody is going to be in a room with a COVID patient or a PUI patient, and they're going to be in a very close distance, they need to have not only droplet precautions, they actually need to have airborne precautions as well. So I work with that assumptions, because if I'm going to apply that to myself, I would want all my fellow physicians, nursing staff, respiratory therapists to have the same opportunity. So that's my perspective. The other thing is that if somebody's going to get infected, it should be a workers' comp situation. And by law, one should not be required to be in an unsafe environment. So that's something that the organizations would have to take a position, very clear position. The hospitals are not going to take it because there's a workforce challenge that we have. But in Italy, the workforce was negatively impacted and the mortality rate is far more. So if you want to save the patients, you need to save the caregivers. And that's our argument that we have to use and educate the policymakers at all levels.
Okay.
It's Dr. Chandi here. I think I think before we proceed, this is a huge issue even in our group, because we're seeing our own physicians drop out from infections. There's two aspects to this. One is the hospitals, and you have to find out what they've done. Some of our large hospital systems have told the house care, the people who clean the housekeeping and the environmental engineering to stop cleaning the rooms, and they said the nurses to do it. And this has created a huge, everyone's focused on masks. But 80% of the transmission, probably 70 to 80% of the transmission is by hands. And when you don't clean the rooms, you've got a viral patina, and this was published recently in the Annals of an Infant, where 6 to 8 feet away, the room was coated with virus. I think it's very important for organizations to take the stance that we must clean these rooms and keep all the surfaces clean. Because when you walk in there and you touch something, and it may get on your surfaces, and you may touch your mask, and then you take the mask off, you touch your hands. It's so easy, and you have to do this perfect every time, 20, 30, 40, 50 times a day. Your chances of doing that consistently over a period of a month are near zero. You know, we must ask them to clean the environment. The second thing was we must ensure that the appropriate PPE is available so we can actually have the resources available. And lastly, it should be covered by workman's comp, because this is what we are. I mean, this is horrendous what's going on, not just for us, but for every doctor. There's going to be 10 nurses that are infected. Right now we have some parts of Chicago on the south side where our group goes to, and it's just like New York, fundamentally no different than New York. So I would certainly expect and exhort the AAPI and all the local medical bodies to take a stance on all these three issues, not just the doctors, but also all the healthcare providers. And I'll stop there.
You know, yesterday a policeman died from COVID-19 and in Chicago, and he was labeled as death in line of duty. So his family is going to get compensation. So I totally agree with you, workman's compensation in this.
Next question is about, I think this is Dr. Siddiqui, about the hydroxychloroquine, Zithromax prophylaxis, and cardiac, especially frontline providers.
Yeah, this is Mukarram Siddiqui from Detroit.
Yeah.
Anupama wanted me to announce the speaker when they answer the question. I'm going to take a few minutes to answer this question because the data that is available is not the data from randomized controlled studies, but these are case controlled studies, one from France, the other one is from China. They have shown that utilization of this combination results in decreased amount of duration of the disease and decreased amount of viral shedding in the patients. So whenever we talk about use of hydroxychloroquine as well as Zithromax and chloroquine, we worry about development of torsade and risk of sudden cardiac death. So to answer this question, first of all, we have to know what we know about these drugs. So hydroxychloroquine and chloroquine have been available for a long time now. Chloroquine since 1934 and hydroxychloroquine since 1955. So far, hundreds of millions of patients have used this all over the world. And whatever data is available through World Health Organization shows the risk of sudden cardiac death in patients that have used this drug to be similar to that of general population, okay? Now, second thing that we need to understand is about Zithromax. You know, there was a study in 2012 that reported, that was published in New England Journal, that was a retrospective study that looked at use of Zithromax in patients that have completed the course. And according to the study, they extrapolated that if you use in 1 million patients, about 46 cases of torsade has happened. But again, no other study has shown the similar correlation that was seen by this study published by Ray in 2012 in New England Journal. Now, taking it a step further, we'll talk briefly about the action of these drugs on the cardiac action potential. When we use chloroquine, hydroxychloroquine, quinidine, or quinine, these are class 1A agents, and they affect the rapid rectifying potassium current, and they tend to increase the QT. They tend to increase the repolarization period and hence affect the QT interval. So there can be a slightly higher risk of development of QT prolongation with these drugs. But again, the correlation between QT prolongation as well as development of torsade is nonlinear. So you can have a QT prolongation, but not all QT prolongations will result in development of torsade and sudden cardiac death. Now, going towards azithromycin. Azithromycin does not act through the hERG gene, and it is not cleared by the CYP system. So the risk of QT prolongation is very low, and whatever QT prolongation that you see with Zithromax is related to increase in action potential duration as opposed to that of repolarization time, that is the QT interval. So really the risk of sudden cardiac death with Zithromax is much, much lower And I have not seen in my practice any patient that had torsade related to zithromax use. Again, the confounding factors in these patients are hypokalemia, hypomagnesemia. So there is something called as a Tisdale scoring system. I would recommend all attendees that are attending tonight to make themselves familiar. Anybody that has a score of 6 or less is at low risk for torsade. Anything between 7 and 11 is intermediate, and anybody more than 11 is high risk. So you got to be very careful initiating those drugs in patients that have a score of 11 or higher. And obviously, in patients that are in-house, you can get an EKG. You can continuously monitor them on telemetry. After 3 to 4 hours after the second dose, you can get a repeat EKG. Outpatient, I have no issue starting this combination in low Tisdale score, even without an EKG. So I think there's something that needs to be looked at. It'll be nice to take a look at it, and as a part of a randomized clinical trial, but we should not throw the baby out with the bath water. So I think this is something to be looked at very carefully. Okay, thank you.
Excellent.
Thank you, sir.
Excellent, Dr. Siddiqui. And the next question I have from St. Louis, Dr. Anu Therukonda. He has a question about patient management of patients with COVID pneumonia not sick enough for the hospital. Can they be managed at home, or they need to be admitted? This is for someone who came to the urgent care.
Yeah, I'll take that question. Mujahid Hussain in Chicago. Yeah, I mean, the patient are not sick enough. I think they can self-quarantine at home. And as you know, there is no specific treatment for COVID-19. So if they start with the clear instructions to the patient that if they start having other symptoms, especially shortness of breath or diarrhea or other changes like mental status, then they need to show up to the hospital. So the answer is you should keep them as much as possible outside the hospital.
The question is, can we give a zithromax or a chloroquine to that patient as an outpatient?
I think there's no clear data to suggest that right now. I mean, we are, people who are dealing with this COVID are using mostly for the inpatient. Outpatient, I'm not aware of it at this time.
Dr. Siddiqui, can you comment on the outpatient? We are concerned on the phone.
We have 3 major health systems in Detroit area: Ascension, Henry Ford System, and Detroit Medical Center. So there is a randomized clinical study that is being initiated in which patients will be initiated on these drugs as an outpatient. So we'll have more information. As far as I'm concerned, I've used it in inpatient with fairly good results, but outpatient practice has been rather limited lately because of inability to see patients. And again, most of these patients are being triaged through ER or primary care physicians. But there are, some of my primary care colleagues that have reached out to me and they have initiated the drug with a low Tisdale score, and these patients have done fairly well so far. And again, this is off-label use. Please document it because it depends upon which part of the country you are, because there are certain states that are more liberal, because our governor, till not too long ago, has been very emphatic that we should not be using it.
Yeah. Next question is to Dr. Tarak Vaswada. The question is, one person committed suicide due to depression associated with COVID. How do you treat healthcare workers with anxiety, depression? Do you treat with antidepressant, psychotherapy? Go ahead, sir. Is he unmuted? Can you unmute Dr. Vasteva?
Tarakji, are you there?
Yeah, he's talking. We're not hearing.
Okay, I'm there now. Okay, sorry.
Go ahead, sir.
Okay, so the rule is that first of all, you have to assess the situation, and if it's a suicidality is present, then you have to treat this as a medical emergency. But you need to realize that people are resilient. In studies done in New York City after the 9/11, people who were in the tower, 25% people had PTSD. People who saw the tower falling down, people who got injured, probably 30% still did not have only 30% had PTSD, 70% did not. So don't think automatically that everybody will be affected. So don't make a crisis out of an event because people are resilient. Second thing is don't pathologize quickly. Don't give a diagnosis right away. You need to do therapy if it's good to do an individual, then to do a group sometimes in a crisis, because group therapy leads to victimization and the role that we play as we are helpless. And also pharmacology is basically limit to the level of to treat mild anxiety, some low dose of that are not addictive. So that's the what I go. But if there is a crisis, sure, we will treat.
Thank you, Dr. Savada. The next question is there any lab doing the stool test for COVID RNA? Anyone can answer?
I mean, so can you say that question? Any what?
Is there any lab doing the stool test for COVID RNA to diagnose COVID?
I'm not aware of it, and at this time, even we should not recommend that because the sensitivity is very low.
Okay.
Yeah.
So is daily low-grade fever of 100.4 a sign of COVID-19, and this patient's first swab was negative? So.
These are the tricky ones. I would be cautious in this. I mean, just having a fever does not mean COVID-19. And, you know, you need to have other symptoms, upper respiratory tract infection symptoms. And obviously in history taking, you need to have sick contacts or travel history, but not just by a fever. I would be cautious.
Thank you, sir. Next question, N95 mask, like everybody, can be sterilized. We have ultraviolet sterilizer in our hospital. It take 1 minute to sterilize. Can anyone comment on N95 sterilization, please?
I don't know.
Anyone? Oh.
Yeah. Sorry, I don't know the answer.
Oh, okay.
So I will answer that question being an anesthesiologist. So we do have a 95 year, we have a 95. What we do is end of the day, we put it in a brown bag and then give it to our OR. They will do a vaporization technique with hydrogen peroxide, and then they will give it back to you the next day. So that's one way of sterilizing. Or you can just leave the mask outside, let it dry 3-4 days, and then still you can use it back again. Also there is another technique where you can put it in a steam, certain temperatures, and in an oven for 70 degrees Fahrenheit. So these are a few techniques which have been suggested by CDC now. So each hospital is using their own technique. So my hospital, we are using hydrogen peroxide vaporization technique. So end of the day, we put it in a brown bag, put my name on the bag, and then just give it to them and they will sterilize it. And also they said like you should not have any makeup on the mask because makeup will not sterilize properly. That's what they told us. Thank you.
Next question from Dr. Raji. If COVID patient in the hospital for more than 14 days, how long we need to continue airborne isolation? How long we need to continue airborne isolation?
I think that question is still out there. Nobody knows the answer. But, you know, whenever after 14 days of a patient being on a ventilator, you do tracheostomy, but tracheostomy carries the risk of further infection. And personally, I have not seen that kind of a situation in Illinois.
Next question, thank you, sir. Next question, Dr. Muhammad, from Muhammad Mustaf. How are hospitals sharing their lessons with each other of what is working and what is not? This will shorten the learning curve and maybe find some short-term success. Dr. Siddiqui or anyone? No.
No, I don't know.
No, the thing is, we have been hit very hard, very fast by this
Thank you.
pandemic. And I do not believe that we have enough data to share because we are just trying to survive at this point. It's like being punch drunk in the first round itself of a heavyweight boxing match. So we'll have more data. I think we'll have a lot of information after this, and we'll be very well prepared for the next pandemic. But right now, we are all trying to survive.
Yes.
So I can add a little bit to it as well, Lokesh. There are literally Facebook communities of physician groups that are formed around the United States, around the different regions, and also we are trying to get the maximum data from Italy, from the Korean experience, and Chinese. So every day, some of the mainstream journals are publishing very good data of the experiences. So, but it will require us to truly go after it rather than it's going to come to us. And I think everybody needs to be involved. There's some 20,000 physicians locally who are on one of the groups that we are sharing our experiences and getting the best practices out there. But since there's so much data, you have to go and verify it because we are all over the place.
Thank you. I have a few questions on BCG. A study going on in Germany and about anti-parasitic medicines. Is anyone have? That's a question we have. Is anyone can answer?
So this is Dr. Saud Anwar. So there's one epidemiologic study that's rotating around which claims that the patients with BCG have some kind of a protection, so their risk of getting COVID is low. I would take that with a huge grain of salt. The reason is that BCG has been traditionally given, in the past it was given to all parts of the world, but then the underdeveloped part of the world where TB is much more prevalent, that's where we started to use BCG. And these are the very places we are not doing the testing. So if you're not doing the testing, you're not identifying the disease, and it gives you a false sense of protection that you don't have the disease. And that's part of the challenge. So I would not look at this as a protective mechanism or a treatment for having BCG at this time. There's no significant, meaningful, verifiable data that we have seen.
The next question is, can you address the ethics of resuscitation and choosing ventilator rationing? Anyone?
I can do that too. This is the Dr. Saud Anwar again, a pulmonary critical care specialist. So this is going to be a real issue that we're going to deal with. But what we have done is we had a meeting with the Connecticut Hospital Association in the state of Connecticut, and we asked them to take a public position and then make sure that the physicians are not put into this situation. So they actually have created a mechanism and a scoring with this SOFA scoring, and then also they're not keeping the age factor in this at this point, but they are willing to put a situation where the DNR, DNI status can be determined based on the probabilities and recommend by people who do not have any other information except objective data at the level of the state to be able to make a call that this patient should not be resuscitated or not be intubated. But I can tell you, Governor Cuomo has said it's okay to have more than one patient on a ventilator, and we have devices where most of the organizations have said they would not look at that as a standard of care. However, when you have 3-4 patients in front of you, you don't have enough ventilators, and you know that you can put extenders on the ventilators and be able to provide them care, it will be difficult not to if you feel comfortable doing it. So we are still behind as a society to be able to do the crisis care at this time. So we are going to have a lot of people die because of our fears and concerns. So it's a mixed bag in that situation as well.
Sure. Next question from Jayant Day. A question for Dr. Vaswada. How do you inspire and lead the healthcare team in this severely depressing situation? So question is, how do you inspire and lead the healthcare team?
Yeah, I think it depends upon the hospital culture and what you have done it before. I'm sure there are a lot of teams that have been good before and they will do much better. You cannot create a team so quickly, so fast. But of course, there are always some good people that rise to the challenge. So you have to look for them, encourage them, sometimes run with the thing. First of all is the hospital has to do it. We have at our hospital, we created the helpline for the healthcare workers, and they will be calling, and this Monday it's going to start. And then they will be assessed, and need-based therapy or group, whatever needed, will be given to them. I think a lot of people in South believe in religion, and they're very religious people. So we encourage them to pray. There are special prayer groups going on, and which people, like it. Recognition, I think this is not time to fight or blame, or so team, it's a teamwork. Whatever it goes in a team, crisis team, same principle applies. We have not worked as well in a crisis situation as we are going to work, like Dr. Anwar said. This is the highest, probably the stress that we have put on our health system. So it's evolving thing. You have to have somebody that people look forward to, like people on this panel that are talking amazing thing here. And those people should lead from the front, doing things, and encourage second, third in cadre, because you don't know who will be sick today or tomorrow.
Thank you, sir. Next question we have is from Dr. Shiva. Publication suggests 10% of COVID-19 patients present with encephalopathy-like picture, acute necrotizing encephalitis. So on that topic, anyone can we?
I think this is Saud Anwar again. So I think this was asked a little bit earlier. The issue is our experience in the United States has not been long enough to be able to see that. But we know from the Chinese literature and from Italian physicians' conversations that people came in with seizures. They had encephalopathy-like features as well. I bet if we started to do CT scans of all of our patients in the ICU, you would see inflammatory changes and then some of the impact in those patients as well. We are not doing those tests right now because it's a big challenge to take the patients down there and then clean up the entire CAT scan. So when the volume of disease increased to the level that it had in parts of China, then everybody was getting all of those tests. And then since we are not doing those tests, our experience and then the duration of illness in the United States has not been long enough to see the long-term impact. So we will be seeing this in 3-4 weeks. We will be expert on this as well.
No.
Yeah, the next question is there a role of convalescent plasma in treatment? Are we doing it?
I can answer that as well. This is Dr. Saud Anwar again for the ones on the phone. So if you look at, I put a lecture online yesterday on this very topic. One of the first treatments in China that they had done, we know from 1918 that plasma treatments from the convalescent plasma was used. We know from the SARS epidemic, there was positive results. We know H1N1 there were positive results, and we have seen recent publication in JAMA where
conference call
critically ill. They actually showed positive results in those patients. So this is a hopeful treatment. We are not doing enough in the United States for a number of reasons. One, we don't have the test as easily available and the antibody test as easily available. But if you look at the Red Cross official website, the Red Cross is already accepting plasma donations right now. So that's going to be there, and people are already coming up with their own protocols. One of the books, the handbook from China that has come out is talking about the details of how the plasma can be used and the infusions and details. So this is a promising option and should definitely be used and considered. And actually the studies that I have seen from SARS, it shows that the earlier you use it, the better it is. So, but Chinese used it very late as well. So their results are even good, but they would be even better if we had that luxury.
Dr. Anwar, there's a question on the same plasma. How early, when the disease most likely by the patient is in ARDS, 9th day, 10th day, when should we think this plasma to be given?
I will tell you about the 5 patients that they were looking at. The patients, they used it at day 10 was the earliest, and day 22nd was the farthest. And all of those patients did well, but the whole idea is if you, and I can only give you SARS experience. SARS virus is about 85% similar to this current virus, COVID-19 virus. And when we look at those patients, when they were PCR positive but antibody negative, that was when the effectiveness was the highest.
So you say average Chinese study coming on 8th or 9th day ARDS. So we should be giving 7th or 6th day, right?
That's if I had a magic wand, that's what I would do, because SARS studies show that when the PCR is positive and the antibodies have not been formed, that is when it's going to be the most effective.
In put it reality, when the patient coming to the ER, so they with most likely COVID and this typical oxygen they needed more. That's when it is, not when you go on the vent. It's too late, maybe 2-3 days late.
I would still use it at that time, but yes, you can actually see the cytokine storm is our enemy in this disease in the critical patient. And if you can do whatever you can, I mean, tocilizumab is being used for it at this time. But when you're using toci, it's good. But if you can go even before the cascade of that change, it would help us out. That is the hope.
Can you do two doses after one doesn't work, second dose?
Yes. They have done it in other illnesses. So if a single dose is 400, but multiple doses are 200 cc's.
One more question I heard is one donor can, how long it takes? So my question is, if you want to put, somebody donated, how long it takes by the time this extract will be ready?
I have not given it to any patient. I can't wait to give it to my patients because they need it. But I can tell you that between the HIV, hepatitis, and some of those tests, it's going to take at least 24 hours. And then you actually have to use some specific detergent to kill the actual virus in the blood if there is some. So it will take good 24 hours to get it prepared.
Maybe say 48. Okay. So because the data has to be mining and get the people ready and all those things, there's a lot of logistical work, and sooner it works. That's what we worry too. There's one more. There is a question about telemedicine. Telemedicine patient only pays for COVID or everything else from Medicare. I can answer that. Medicare pays everything. Telemedicine, not the COVID, not the bronchitis, sinus infection, new patient follow-up. Anupama, next question.
This is from Dr. Mahadevappa. He's from, don't know where he's from. So my friend was moonlighting at a Centara facility in Southern Virginia. There was no N95. When he complained, they terminated his contract. Any recommendation from AAPI? So this question.
Hello? Vinishji, how are you?
Who will answer before I say anything? Anyone? No. So, any recommendation from AAPI? So we have heard, not this particular physician, but several physicians have been fired, terminated because they were, everything related to the personal protective equipment. So at one hospital, they kind of, all the physicians went on, they complained against the administrator who fired, or so that administrator was fired actually. So you can, you just don't have to be, disappointed or, that you're terminated. But if any one of us have this same problem in our workplaces, I think all the physicians in that hospital have to get together and then work against the administrators for not giving the PPE. This is not just the AAPI related issue, but it's us as physicians. I think we all have to work together at your workplaces and come up with something when you are terminated in that situation and it is not ethically correct.
I will just add something, Anupama, on this as well, that, majority of the physicians now are employed physicians. In the past, the physicians used to have their own practices, and that age group of patients, the physicians, is decreasing. The time has come for physicians to unionize. This is unfortunate, but this is a reality, and some of the ways how the physicians are being treated by large organization is unfair and unethical, and it's harmful for the patients. And if something good can come out of this whole thing, is that there will be an opportunity for physicians to go back to the drawing board and plan to unionize so that nobody can push them around and put them at risk at all.
Yeah, that was another question by another physician. Should doctors have a union to protect us from these kind of situations?
I can tell you in the state of Connecticut, if you're employed by the state, you can unionize. But if you're employed by a large organization, there is it's not an easy process. So if you look at some states have made those attempts, but it will require some changes in laws and interpretation by the Attorney General of the state to allow this. So this is something that I'm hoping, at least in the state of Connecticut, to work towards, because I feel that it's time for the physicians to form a union as well, because majority of the physicians are now employed physicians.
Just one question. President Trump eager to reopen the country. Any plans on checking viral PCR before saying the person has recovered, as IgG will be positive for a long time before going back to work? Dr. Balapala from Houston.
I can answer this too. This is Saud Anwar. I can tell you what the Chinese data is showing. They actually they were using a lot of steroids. So in China, they were using a lot of steroids, and as a result, patients, 14% of their patients were getting readmitted, and they were calling this as reinfection or recurrence. And that was because they were on steroids. When the steroids were over, the viral load started to go up, and then PCRs were positive. So it's arguably in some of the patients, it was going up to 30, 35 days. And the recommendation that they had for their discharge was they wanted to have on the non-steroid patients to test PCRs negative over 2 days. That's when they would discharge those patients. And we can't even get it on one patient at 1 day. So I don't know how we're going to get these in 2 patients over 2 days. And that's part of our challenge right now in different parts of the country.
Yeah.
I'm going to make Dr. Juzas from Australia in Sydney. We have a blanket rule that every COVID-19 patient outside the ICU will have their goals of care discussed, the same policies from British Columbia. So I'm sure our palliative teams are doing it as best as they can here. Is anyone want to comment on that, sir? Before the palliative care for them in the hospital because of they're discussing or they don't have any time.
Dr. Vasavada or anyone can answer the question.
No, next question. There's so many questions. Multiple patients on ventilator. What should E be the initial tidal volume? I don't know.
So I can tell you now, this is an interesting area that I would have, last week I would have given you a different answer. This week I'm going to give you a different answer. The issue and what we have been dealing with is people are thinking that we are treating ARDS, but this is not acting like ARDS, even though the lungs are showing bilateral interstitial infiltrates, and then on the x-rays they look like alveolar infiltrates. We are not CAT scanning as many patients as people in China were. But when you give them the PEEP, you're not necessarily improving their oxygenation too much. So now the thought process is that there is microthrombotic process that is causing bilateral infiltrates in the lung and oxygenation issue. So high PEEP is not needed. And in the past, I would have said high PEEP would be an answer. But right now, the best thing is if you can actually not intubate the patients, if you can get away with it, use high flow nasal oxygen and have the patient lay in prone position, that when the oxygenation improves, you can buy yourself about 2 days. And this would be relevant when you don't have enough ventilators, but giving high flow oxygen with the nose and laying them on their stomach would improve their oxygenation enough that you can get yourself 2 or 3 days in that situation. But then if you're pushed into intubation, then use low tidal volumes and permissive hypercapnia may be a consideration. And you can use, again, 4 to 6 cc's per kilogram is the tidal volume that I would start with, and adjust it according to the blood gases. And if they need 100% oxygen and your oxygen levels are still low, then you may have to start to dial up the PEEP in those patients.
Sure. Next question by Dr. Grande. Can someone explain antibody testing, that is 5 minutes testing? Are they freely available? What is the time frame? Dr. Siddiqui or Dr. Anwar or anyone?
Yeah, I can answer that too. Dr. Saud Anwar again. So I can tell you that in about 2 to 3 weeks time, it is going to be much more freely available. Right now, this availability is quite sketchy. But this is very easily doable. We do IgGs and IgMs on all the other illnesses. We just need to do it for COVID as well, and FDA has approved it. Now we have a 15-minute test in some parts. Abbott has started this test, Abbott Laboratories. I know one hospital in Connecticut has it. Now we are going to try to get it to all other hospitals, and ask your hospitals to be ahead of the curve if you're in part of the country where it's not spread too much. So be ready and be ahead of the curve if you can push your hospitals to have it sooner.
This antibody test, they're testing the COVID-19 IgG?
Both
or
IgM and IgG.
Oh, okay. So when is this patient will be ready for donating plasma? They have no IgM, or they, can you put light answer?
So the IgG is what is more beneficial in the effectiveness, but that would take many days before it would happen. The way is to, when the IgG is high, that's when you are more effective. So not necessarily the IgM.
So whether the IgM there or not, don't worry. The number is higher, then only they're ready for it. Okay. Anupama, I have next question.
Yeah, there's a question from Dr. Saraswati from Boston in Massachusetts. Being in a big corporate hospital, every day we get emails not to mention our hospital name to press or COVID talks. Do anyone else have the same situation? Anyone of you can answer.
Yeah, they're flooding with so many emails on an everyday basis that it's just hard to catch up all those. But we do go through the main ones, and the email has so many links also, so that becomes another problem. So it is tiresome.
Yeah. That we have been hearing that often recently. So the hospitals and I think the administrators are getting anxious, and they are asking their physicians not to talk about anything. Some of them are confidential information you get every day in your emails. So they do let you know what is something which should not be discussed outside. So you get emails in your daily emails. I get everyday emails from my administrators, like what to talk, what not to talk, what's going on in the hospital, what's going on in the city, what's going on in the other hospitals. And each hospital also, they are communicating with each other what's going on in their hospitals. So there is I'm from San Antonio. We are a small town, but we have 4 major hospital systems here. So they are all discussing internally with each hospital, and they're coordinating really well. I hope every hospital system in the other cities also are doing same thing. So be careful and watch out what's going on in your own hospital. And there's a question from Dr. Lal Malani. He's our past president of AAPI. And there are several questions, similar ones actually. So let me put together. Hydroxychloroquine use. This is a constant question we have been hearing from all previous talks. Still, we have the same question: can it be used as prophylaxis for frontline workers who take care of COVID patients?
I can take a shot at this. This is texted to me by my colleagues almost every day. I'll tell you what I do, and you can take that with a grain of salt. First of all, scientifically, as of right now, we have no evidence that it works, and I don't use it. I do hands-on care for COVID patients when I'm in the ICU. So despite that, I don't use it, but I stay hydrated. I try to take vitamin C, and I take L-arginine and fish oil, but I do not take chloroquine, hydroxychloroquine right now. The reason is that I will take it if I start to get fever. At the drop of a hat, I'll start that, and maybe Zithromax, but prior to that, I'm not doing it. But if somebody has any data, and that I would love to hear about it, because I haven't checked the data in the last week on this issue.
Any role for zinc?
Go
Any
ahead,
role?
Zinc, yeah, that's other question, zinc.
Yeah, so people are using it. The only zinc data that I have seen is in vitro studies, but nothing in vivo. So I will, I'm not using that, but I've heard of people using it. The other thing is there's no downside to it, so might as well.
Okay. This question is Dr. Siddiqui about the CPR in our community. Being a cardiologist, what is the experience? I know in New York said they're not able to do any more CPR people to ER. Dr. Siddiqui, can you expand on this?
CPR, you mean available personnel to perform cardiopulmonary resuscitation?
Yes, on COVID and also in the community people coming. So what is the situation in Detroit?
Well, I can talk only about our hospital system, and it's all positive. We have enough house staff, and nurses have really stepped up, and they are doing a commendable job. Obviously, the number of patients and the ventilator ratio is not much different compared to other hospitals, but we have learned to work with it, and I don't think we have let any patient go because we were not able to resuscitate the patient. So I think it's all positive here on our side of town in Detroit.
Okay, good, excellent. Yeah, I think New York is too stressed. That's why I think other states are able to handle it right now.
Mm-hmm.
Yeah. One more thing I will add, Dr. Einstein could not able to, and he's a ER doctor, and he said that Washington, he's been there with, 2 months, and their numbers are looking better, and they have ICU beds are empty. I mean, they still have space, so things are coming down there. The one thing, good thing that he felt is, which in America are not ready to do, any COVID positive, he's saying put in a hotel, give 3 meals a day for 2 weeks. If they're sending home, they're going around, they're not. So this will give multiple spikes. That's what he's scared of. Anupama, I have a next question.
Yeah, the question is post-exposure antibody test, is it recommended for family or staff if asymptomatic?
I can answer this. See, the antibodies would start to go up. IgM will go up after about 6-7 days. So you're interested to know if the person is infected and infecting others. So it's a little late to have the antibody test. It's not of that much value. The PCR is going to be the better value. And then the test for the nasal mucosa is better than the throat swab. The nasal swabs are much more a positive predictive value than the throat one. So that would be the first test to do rather than the antibody test.
Yeah. Next question coming from Nahida. What is the best drug combo dose would you take at the first sign of infection if you're a healthcare worker? I think we have options of 4 now. Chloroquine, hydroxychloroquine, and Zithromax, of course, a small dose of steroids. Sir, anyone? Doctor?
So I can add the dose. So hydroxychloroquine, again, keeping in mind that you don't have a prolonged QT interval and you're not taking any of the medicines that are going to prolong your QT interval, the recommendation that I am going with is the hydroxychloroquine loading dose 400 milligrams twice a day, day 1, and 200 milligrams twice a day for 4 more days. And Zithromax 500 milligrams daily for 5 days. I am hesitant about the steroid right now, but open to learning more about it.
Dr. Siddiqui, can you add anything for that? If you don't have
right. Important thing is to avoid hypokalemia, hypomagnesemia, assess the hepatic, any history of liver failure in the patients, make sure that they do not have kidney disease, and look at the age of the patient. And female patients are more susceptible to QT prolongation and torsade. So those are the things that you need to look at and be cognizant about it. Those are not contraindication, but you need to be more careful in those patients.
Another question from Dr. Mahadeva. I'm a pulmonary physician working in a hospital, not ICU. If I have a parent with history of treated cancer, how much I'm bringing to my parent who lives with me? Oh, this question I can answer my own. There are a lot of questions. They said that person, the parent, the family has to be completely isolated. As a physician, you have a time bomb to give it to the family. So that's my person. Anyone else can add that, sir?
I can tell you what I do. I'm in a similar situation. I have family members who have elderly. My in-laws are here. They're elderly. So I go to the hospital and then I come and live in a room. But when I go to the hospital, I actually wear covers on my shoes, just like in the OR. And then I actually do go to the operating room area and change into scrubs and leave my home clothes over there, and then spend the entire day in the hospital, whatever time I'm going to be there, and then go back and change my, take my hospital clothes and then come with the new ones, my home clothes, and then go to my room and pretty much live like this for the past 2 weeks, because we can't afford to get our family members sick. And actually in the ICU, I'm sadly seeing family members of the same family all in the ICU, and it's a contagious disease. So seeing it in that form gives me a lot of respect for it. I'm trying to protect my family in the process, and especially the vulnerable in the family.
How about other doctor, Dr. Hussain, Dr. Sadiq? What do you do?
Yeah.
You know,
What I do is, I have bought scrubs now. I don't wear a regular pant, shirt, or jacket. And when I come back from work, I just go straight to my bathroom and take a full shower and put those clothes in the garage to be clean again. And, that seems to be working, but, the skin is getting so dry that you're putting lotions all the time.
How about Dr. Siddiqui? What do you do?
I'm pretty much doing the same thing, leave for the hospital in scrubs. And then when I go to the hospital, I change into hospital scrubs. And then after I'm done rounding and all that, I change back to my home scrubs, come home, take the, undress in the garage, keep my shoes and socks out in the garage, then come and take a shower immediately, and then change into home clothes.
So I'm assuming that we should recommend all healthcare workers and also everybody who are exposed to maybe talented receptionists like those people, they should be same way. It's not spread unless a politician takes itself. One thing I heard, good thing is I heard the Ohio governor want to make, he want to wear the mask. It's not the mask, of course, I agree the viral particles are on the solid surface. It is a message you send, so it's preventing from their mouth coming, and it is, but they're not inspiring. That's what I'm worried. Next question. Anupama, you have any questions?
Questions are being repeating actually, but anyway, let me ask this question on the PCR and antibody. So this is regarding the development of antibody against the virus in mild to moderate severe COVID disease. Question is, how soon the antibody in the blood peak and how long remains protective for the future wave of virus infection?
This is Saud Anwar. I can try to answer that. So if somebody has the IgG, a higher amount of IgG that's available, then they should be protected. Now, I mentioned earlier in one of the conversations that 14% of the patients were getting readmitted. If we look at the details of those patients, they were actually either on steroids, tests were false negative. You have an explanation on those. There's always a fear of mutation. And based on the mutation risk, you think that your immunity is not going to be good enough for the previous version of the infection. As of right now, there's nothing in the scientific literature that suggests that. There's one study that the Chinese did, which was quite interesting. They looked at about 12 rhesus monkeys. And then they infected the rhesus monkeys with the coronavirus, CoV-2. And when they did infect those monkeys after they had improved, they reinfected them with the same amount of virus, and none of them got the disease. So they're doing some quite risky studies there, because animals is how became the source of it, but they're still doing some of that studies. But that study gives us a glimpse that at least right now, from the version that we have seen, we do not get reinfected. And mutations may come in future. We have to be cautious of that, and that will be the 2 or 3 year pattern that we will see of the vaccination. Maybe it will be a yearly vaccine going forward. But right now, if you get better, you are going to hopefully be good.
Yeah. Next question about pathology and autopsy, are they doing any lung biopsy for more information on pathology of disease? Are they doing postmortems on some patients for future?
I can answer. I try to answer this, Saud Anwar. So I can tell you the only ones that I've seen are from China. I've not seen any from the United States in the published literature right now. And the reason I'm trying to hunt down the details for this is that, remember I mentioned earlier that we are talking about microthrombi, because physiologically these patients are not sounding like ARDS fully. And then I wanted to see if there were microthrombi that were found in the kidneys as well as in the lungs, because people are having renal failures as well. And I have not seen anything from the United States yet. And we really need to get ahead of that responsibility because we have a lot of those patients coming in. We need to get enough data. So that would be worthy to talk to the medical examiners if they can get us some of this. But the Chinese literature showed some of the liver impact, kidney impact, lungs are the main organ, and the heart disease as well as an impact as well. So these are the target organs of the virus and including the brain, of course.
So other question is Indian home remedies such as turmeric, steam, salt water. So you hear a lot of them. Anyone can comment? Okay.
I would just add, if it's not harming you, take it.
Yeah, that's what everybody recommends. Yeah. What is the current sensitivity, specificity of private labs versus state labs? And also, maybe you want to expand. And currently, I heard that even COVID positive, 30% false positive. Anyone can.
So the best test is going to be a bronchoscopic test with the lower airway. See, COVID is a lower airway disease for the lungs. And the best test is a bronchoscopy, and you do a PCR on the bronchoscopy. But that causes aerosolization, puts everybody at risk. So nobody's going to do that. And it's not smart to do that. So you do the nasal, one is the second best, and CDC requires you to do a nasal as well as the throat together, and that increases the yield. If you have it is in the high 80s from what I understand the sensitivity. It is not necessarily the gold standard, and that's why people were doing multiple tests to get more clarity around it. We are not doing multiple tests. We actually have stopped doing the tests because we are doing it only on inpatients. We are not doing it on outpatients, at least in our area right now. But the tests are going to be PCR going forward in the initial exposure state. And the antibody test is much later, and they are much more sensitive for the antibody, but they're a little late in the game.
Thank you so much. I think it's 10:30. Is there any more questions, Dr. Idara, or we can conclude the session?
One question from, I think it's pulmonology, that question can answer. High PPEP-ventilation Seattle experience with COVID had plateau pressure and mean of 25 centimeters per water, and driving pressure mean of 12 centimeters per water. Recommendation, your recommendation on PEEP.
Yeah, PEEP, initially we thought it was going to be high PEEP, but, these days, meaning the last few days, 5 to 10 PEEP is enough, but the plateau pressure has to be less than 30. And I think that to prevent any barotrauma, obviously.
Yes.
And also, we actually thank a lot of callers give their own opinion, which I can see on the screen, and it's very self-learning because we're not able to accommodate all the questions, which are very, very valuable. Go ahead, Anupama.
Yeah. Thank you. Thank you so much, Dr. Mujahid Hussain, Dr. Anwarji, Dr. Taraji, and Mukram and Suresh Reddy for giving the opportunity for all the frontline physicians who are daily managing these patients. And we would, on behalf of AAPI, we thank all the physicians who participated in this discussion. And I'm sure we haven't answered 100% of all the questions today, but time is running out. And we will continue these. We would like to do 2 sessions a week. So we may plan one in the midweek. Hopefully we'll come up with more questions and with more questions from.
One more question. It's a disclaimer. All the opinion is a discussion forum only for AAPI. AAPI is not liable for any. It's not AAPI's recommendations. So we wanted to keep that one too. Can we have a closing statement from one speaker at a time? Dr. Hussain, sir.
Yeah, my advice to all the healthcare is just be safe. This is a deadly disease. It is infectious, going from one place to another, and be careful and do your best.
Okay. Dr. Siddiqui, sir.
I wish everybody the best of luck, and I want everybody to be safe. And whenever you are confronted with a COVID-19 patient, after taking the precautions, if these patients need ACE inhibitors or ARBs, do not hesitate to do that. If the patient needs to be started on anti-malarials along with azithromycin, monitor the QT interval, look for changes in QT interval, and deal accordingly. And the very best of luck. I wish this pandemic will get over soon.
Thank you so much, sir. Dr. Anwar, sir.
Sure. I would just say thank you so much for this opportunity. Please stay strong. Take care of yourselves emotionally, physically, spiritually. This is unlike anything that we have seen. This is actually testing our medical capacity of truly learning as we go. Stay involved, because a lot of what we are learning, what I knew about this disease about 2-3 weeks ago, and what I know right now are totally different things. And that's why we have to stay engaged and continue to look at what's happening. And end of the day, we are in a war, and in the battle, you have to improvise to survive and make sure you are taking care of the person you're taking care of. So think of improvising, think of surviving, think of standing up and protecting yourself and your families in the process, and know that you're not alone. Thank you for what you do.
Thank you so much. Dr. Tarak, sir, can you have comment?
I would like to say that, like previous speaker said, it's adversity that we have not seen before. So don't feel guilty if you don't succeed here, something goes wrong. Don't blame yourself. Gratitude. Thank every day of what is good in your life. Reach out to your family and partners. Seek support. Even discuss some emotionality of your part, how you feel scared. It's okay, because it's a rough time. And again, we just hope that we all will be okay, and we will have better times to come, probably.
Thank you.
Thank you so much. Dr. Suresh Reddy, you want to close?
Yeah, can you hear me?
Yes, go ahead.
Okay, thank you so much. Thank you all the speakers, especially my good friends Mujahid Hussain, Mukarram, and Tarak Vasavada, Dr. Saud Anwar, and Dr. Chundi. And thank you for joining, and thank you for sharing your knowledge. And this is, I think, almost like a 10th session going on with almost 5-6 speakers. So we had almost like 50-60 speakers, and almost 500 times 10, like 5,000 audience. So it's a very educative experience, learning experience for everybody. And it's also like a therapy session for all of us. So let's keep it going. Please join us. We have one coming up next Wednesday. We are doing every Wednesday and Saturday. And thank you so much.
Thank you. Good night.
Thank you very much.
Thank you.
And we see some of the from physicians will ask their help and their expertise in next future meetings. Thank you so much, sir.
Thank you.
And if anyone would like to do panel speakers, I think you can text us, and we encourage you, because you're all frontline physicians working on this, and this is a new disease. So we all like to learn from all of you too. Yeah. Thanks.
Thank you.
Thank you, sir.